Hello and welcome to Biliary Atresia webinar. I'm Farah Douglas, President and CEO of the Liver Health Foundation. Since the early days when I started my work with liver patients, biliary atresia has always been of interest to me because of its impact on infants as well as teenagers and adults who have had Kasai surgery earlier in life and are living with their native liver. Some have had liver transplant. In tonight's program, we will hear from our medical experts about biliary atresia. There are some things that we know about this disease. It's a rare congenital liver disease affecting newborns. It scars the liver and blocks bile ducts, and the telltale sign of BA is jaundice and light colored stool. From my past interviews with parents of BA children, I know that hearing the pediatrician telling the parents there seemed to be a problem with the baby's liver is one of the most frightening things a new mom can hear. Tonight, we will talk about all these issues and more with our panel of experts. I hope this webinar brings new and important information to you. Liver Health Foundation is proud to host these free educational webinars to raise awareness of liver disease and to educate patients. We are a patient advocacy 501c3 nonprofit organization with the mission to support liver patients, their caregivers, and family members. We operate in Los Angeles, Inland Empire, Orange County, and portion of Arizona and Northern California. In tonight's webinar, Dr. Rohit Kohli will offer a comprehensive review of biliary atresia through a PowerPoint presentation. At the conclusion of the presentation, we will begin a roundtable discussion with Dr. Jaslin Singh and Dr. Kambiz Etesami. During the roundtable discussion, our experts will talk about their own experiences in working with BA patients and their research on this disease. If you have any questions, please use Q&A or chat function and post your question. Our experts will try to respond to all of them. Please remember, information given by our expert is not a substitute for advice given by your own physician or healthcare provider. We do not endorse doctors, hospitals, medical centers, treatments, or pharmaceutical companies. This program has been made possible by an educational grant from Epson Pharmaceuticals. We thank Epson for their support. I am honored now to introduce Dr. Rohit Kohli, who has generously agreed to be the presenter for tonight's program. Dr. Kohli is the Chief Division of Gastroenterology, Hepatology, and Nutrition, Associate Director, the Saban's Research Institute, Associate Chair in Liver and Intestinal Research at Children's Hospital, Los Angeles, Professor of Pediatrics, Clinical Scholar at the Keck School of Medicine, University of Southern California. Dr. Kohli received his medical degree from the Armed Forces Medical College in India in 1999 and his MS in Clinical Investigation from Northwestern University in 2006. While at Northwestern, he first spent 3 years as a pediatric gastroenterology and hepatology fellow, and then subsequently as a transplant hepatology trainee before relocating to University of Cincinnati in 2007, and then to Children's Hospital in Los Angeles. Dr. Kohli has published many peer-reviewed articles, including articles in Nature, Nature Review, the Journal of Biology, Chemistry, Hepatology, Journal of Pediatrics, and the American Journal of Physiology. Dr. Kohli is a recipient of the 2007 George Ferry Young Investigator Award from the Children's Digestive Health and Nutrition Foundation, a fellowship award from the American Association for the Study of Liver Disease, AASLD, Takeda Research Innovation Award from the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition Foundation. Dr. Coley is a member of the American Pediatric Society and a member of the Liver Health Foundation's Medical Advisory Council. He received Liver Health Foundation's Healthcare Visionary Award in 2022. Dr. Coley, welcome. We are grateful to have you with us. Thank you for your support and participation. We are ready for your presentation.
Thank you, Farah, so much for this very kind and long introduction. I feel humbled just being part of the team here. So that is my best introduction. Let me start with sharing my screen. Please let me know if you can see it properly.
Looks good.
All right, perfect. So the topic today is biliary atresia, and love to see a discussion at the end with the other panelists. So I will try to keep this a little bit short so that there's more time for interaction and discussion and answering questions from the general audience. These are a few companies that currently I work with and also with the National Institutes of Health. So I'll leave this up as in terms of my disclosures for a few seconds. I will not be mentioning any specific medications by name today. So the outline of today's talk, part one, the basics of this disease. It's trying to understand the background and the pathophysiology, what we know today to be the state-of-the-art understanding of biliary atresia. The second most important thing after diagnosis and understanding the disease is what can we do about it? What are the outcomes from the current interventions that are available in medicine and medical care? And last but not least, briefly touching on the future, what is on the horizon, what can we expect, changes and newer things within the paradigm of diagnosis and treatment for biliary atresia. So this is a cartoon. We have the links from where I've taken the cartoons at the bottom of the page. If you're interested, I'm showing first the normal biliary system in green, highlighted in fluorescent green. You can see the liver is in orange, pink, this triangular organ. The green thin tubes are what we call the hepatic ducts. This is looking at a patient face forward. So this would be their left duct. This would be their right duct joining together to form the common hepatic duct, which then supplies the gallbladder, which is filled with bile. When we eat, this gallbladder will contract in a normal circumstance. There is some drainage from the pancreas into a pancreatic duct to form the common bile duct with the confluence of all of these entities, which then empty into the duodenum, which is this part of the small intestine just after the stomach. So what you see is when food enters the stomach, a signal goes to the gallbladder to contract. Bile is drained through all of these tubes into the intestine so that food can be mixed with bile for better absorption and other things such as bile-driven signaling processes. Unfortunately, in children who have biliary atresia, there is a problem in these ducts. They're born, we understand to the best of our knowledge, normal. However, we call biliary atresia a progressive cholangiopathy. Cholangiopathy refers to the fact that these cells that line the gallbladder and the bile ducts are cholangiocytes. These are special cells. And when there's a problem with these cells, we call it a cholangiopathy. And progressive fibrotic cholangiopathy is what we understand biliary atresia to be. And the word fibrotic means scarring. So what happens is here you can see the hepatic duct has become very, very diminutive, scarred down. There is little or no bile flow. The cystic duct similarly, all of this and the gallbladder has become what we call shrunken and atretic. So when these shut down, these pathways scar down, fibrose down over the first few weeks of life, we start to see a obstruction in the flow of bile, which of course then manifests as jaundice in the child's eyes and skin initially. And of course, the color that would typically have been part of the bile draining into the intestine and mixing with the food and then finally into the stool is no longer there. So we will go over in a second the absence of this color in the stool as a sign for biliary atresia when no bile flows into the intestine. So overall, a child that is born completely looking normal, eating fine, sleeping fine, suddenly starts to have jaundice, which is not resolving, and the pediatrician will do some tests and understand that this is a type of jaundice, not similar to what we call physiological jaundice, where you have a almost a large percentage of children who are born can have that, but that resolves. That is a different kind of jaundice that has nothing to do with bile ducts. That is just the immaturity of the liver, but that's temporary and it resolves. However, in this case, this scarring is permanent and it happens all across the bile ducts, wherever they are, whether they are visible ducts like here in the gallbladder and in the cystic ducts, or in the tiny, tiny ducts inside the liver as well, which can only be seen on liver biopsy where there is fibrosis happening inside the liver itself. So how can we diagnose this? This was the American Academy of Pediatrics published a position paper back in 2015, led by Professor Casper Wong, who is now at the Sick Kids Children's Hospital in Toronto. He, leading the Committee on Fetus and Newborn, and also representing the Childhood Liver Disease Research Network, which is sponsored by the National Institutes of Health. And they published this an analysis, and they said that we should consider as a community newborn screening for biliary atresia. This does not exist at this time, but this is a consideration put forth by this committee where you would look for conjugated bilirubin concentrations or stool color cards. And I will go over both of these things in a second. I just mentioned that physiological jaundice, where you have the bilirubin high in quite a large number of newborns, which is temporary, it goes away. When you have that jaundice, that is the total bilirubin is elevated, but the parts of the bilirubin that we are interested in, one of them is called conjugated bilirubin. That is what is mentioned here in biliary atresia and some other diseases that are abnormal pathologic diseases. There is a increase in the conjugated fraction of the bilirubin, not just the total bilirubin. And that is a key point of distinction that I will go over in the next slides as well. And the other opportunity is to educate parents and caregivers, including primary care practitioners, about the color of stool by using stool color cards. So this was a very seminal paper published in 2011 in the journal Pediatrics by the group from Texas Children's led by Sanjeev Harpawat. And what they showed was that within the first day of life, if you looked at total bilirubin, there is going to be a large variation. As we know, a lot of children can have, infants can have elevated total bilirubin. So here we have the acronym T and then B, total bilirubin. And when you look at that, you cannot distinguish children who are normal or controls versus children who have afterwards being diagnosed with the disease biliary atresia. And you can see all these dots for total bilirubin, all these dots for total bilirubin for these two groups. They're overlapping. There is some slight significant difference in the higher level here, but there's a lot of overlap, so you cannot distinguish between the elevation that clearly. However, when you look at DB here, direct bilirubin, direct and conjugated sometimes are used interchangeably for that fraction of bilirubin that is important in this disease diagnosis. So direct or conjugated bilirubin all the children who had biliary atresia had high levels of direct bilirubin, whereas the controls did not have elevated direct bilirubin. A very nice cutoff was seen between this group and this group. So this was a pickup from the group in Texas Children's, which was critical and goes into the thought process of the potential for using direct bilirubin early on in the first few days of life as a screening test. So patients with biliary atresia have elevated direct bilirubin, but not total bilirubin, in contrast to children who are controls who have no biliary atresia, as far as was detailed in this study. The second thing that distinguishes, as I mentioned, when there is this fibrosis or scarring of the bile tree, whether it is the gallbladder or the bile ducts, and therefore the bile cannot flow through them, is that the stool color will change. At the bottom here, you see normal colors of stool. You see orange, you see green, brown, but in the top three panels here, these are very pale colored stools of infants, almost chalky, pale, clay colored. Different terms are used, but you can see the distinction. Here, the bile is probably flowing normally through those bile ducts into the intestine to mix with the food. And here, there's a problem with that bile flow. It's obstructed, therefore the color is gone from the stool. Sometimes in the literature you will see, if you're reading for diagnosis of biliary atresia, a test called a HIDA, H-I-D-A, is mentioned, which is a test where a dye is injected into the veins of a child. It's taken up by the liver, concentrated into bile, and then pictures are taken radiographically to watch where the dye goes. And if it does not come into the intestine, it is something as a sign for biliary atresia or an obstruction in bile flow. But here you can see the same sign just by looking at stool color. The sensitivity and specificity of looking at the stool color is similar to that, because the physiology behind that, as you can understand, is very much the same. More recently, there is another test that has been talked about. This is MMP7 as a epithelial marker of injury in the context of biliary atresia. Here you can see children who had biliary atresia. This was research done at the Cincinnati Children's Hospital, led by the group with Georgie Becerra as the lead author, senior author. And the red dots, as you can see, are children who have biliary atresia for this blood marker MMP7, compared to children who are normal, do not have biliary atresia, or another liver disease, not biliary atresia. So very promising marker, not something that is in everybody's toolkit yet, but a promising marker. And here is another one, which is bile acids. Again, red dots depicting bile acid levels in children who have biliary atresia, and these diamonds, non-biliary atresia patients. And you can see the negative predictive value is not that high, but the positive predictive value of bile acids elevation is high, because there is some overlap here between these two groups. Again, the development of these tests is in parallel, because the bile acids are also part of bile, just like the conjugated bilirubin is. So this was the basics. Let's talk about what the interventions are that we can do currently. The surgeons, once we highlight to them that there is a suspicion of biliary atresia based on the stool color, the blood tests, and or a liver biopsy, which I am not going to go into details about, but the first line of treatment is confirming the diagnosis with what is called an intraoperative cholangiogram, where you are going to, you as a surgeon, go in and use a direct attempt to cannulate one of the bile ducts or gallbladder, inject dye, and to see if there is a lighting up of on X-ray the bile ducts. If that is present, if the normal ducts are visualized, if the gallbladder is seen normally, then of course there is no biliary atresia. However, if there is confirmation of biliary atresia, meaning that the bile ducts are fibrosed or the gallbladder is atretic or both of the situation, then that is how the gold standard diagnosis of biliary atresia is made while the child is under anesthesia through the intraoperative cholangiogram. Once that gold standard has been met, the step next since the 1950s is to do what is called a Kasai hepatoportoenterostomy, or also known in lay terms as a Kasai surgery. Here you can see the liver is not pink, not healthy looking. It is already very green. Here you can see they have isolated the ductal structures. And what is done in a Kasai surgery is complete excision of the extrahepatic bile duct, the atretic remnants that are there, and then anastomosis of an intestinal piece or intestinal limb to this plate that has been exposed, where there are mild drops of bile coming out of the ductules. Therefore, you're draining the bile from the ductules directly into the intestine. Of course, we are not treating the underlying liver disease. We are just re-anastomosing the intestine directly to the liver instead of depending on the ducts that unfortunately now are scarred. And since the 1950s, when Dr. Kasai described this procedure, the Kasai surgery is the primary methodology of, the term we use is palliation of biliary atresia, as we're not curing the disease, but we are trying to restore the bile flow for a significant period of time. And what you can see here, this is a published abstract, courtesy Dr. Frank Sinatra. He had kept this book from the 1980s. Where Dr. Peter Altman's group in Columbia University, New York, looked at the number of patients that cleared their jaundice as you see the age in weeks at which the Kasai surgery is done. If you do it sooner, there is a 5 to 8, 9 to 12, there is a significant number of children that are draining bile normally afterwards, versus if you do it above 3 months of age, it is not successful. Similar data from across the Atlantic Ocean with King's College Hospital London from Dr. Alex Mowat's group, again showing the age of operation being critical. If you do it too late, then you are not going to get bile flow. 11 out of these 14 children did not have bile flow if you did it after 12 weeks of age. This has not changed. This is more recent data from the University of Colorado, combining their data with Columbia from the 1970s all the way to 1996, and then Cincinnati Children's reporting their data from 1983 to 2009. Again, the Kasai surgery has remained robustly the main way to deal with this at the infancy stage. Here, we're talking about a percentage freedom from failure or survival with native liver after the Kasai surgery. And this is years post-Kasai. As we get further and further away, unfortunately, less and less children. You start with 100%, and by the time you get to 20 years, only about 10% or so of children now becoming adults have survived with their native livers. And this is the survival probability, again, 100% down to 0. And you can see when you're 200 months out, similarly, we are down to almost the 10 to 20% range. So the summary of this section would be that you have to have a timely diagnosis. Hence, we started the discussion with screening. You have to do the Kasai hepatoportoenterostomy as early as possible. I sometimes equate the direct or conjugated bilirubin being elevated in a child to the pediatric liver specialist's emergency, because you want to respond appropriately and bring the child to the attention of your surgical colleagues so they can do a Kasai surgery and reestablish bile flow. As we just saw, the sooner you do it, the better the outcomes. Less than 60 days of life, the data tells us it is 70% successful. That is long-term success from a Kasai surgery. More than 90 days of life, unfortunately, less than 25% are successful. And this is defined as the absence of clearance of conjugated or direct bilirubin at 3 months after Kasai. That is the definition of success or not success. So time definitely is bile. So biliary atresia, of course, unfortunately, not all children can get the Kasai surgery in time, and those that do also, there is an attrition, as you saw, over months to years, ending up needing a second level of intervention, which is liver transplantation, such that biliary atresia, here depicted as the major component of the blue color, which is cholestatic liver disease, and the first name listed in this long list of indications for liver transplantation in children, is the majority of liver transplants for children happen for this one disease entity called biliary atresia. So, and this is worldwide. Our program, for instance, started back in 1998. We've done more than 500 transplants now, and it showcases this beautiful smiling child was our 400th, and we're doing about 30 to 35 transplants a year with a 1 year 100% survival. But there is a debate, academic debate, I would say, of doing Kasai versus primary liver transplant. And if you look at this data, which was published by Professor Alexopoulos from Nashville, Vanderbilt University, they talked about an increased early risk of mortality in the primary liver transplant cohort. If you don't do a Kasai and you directly go to liver transplant, you may have increased mortality, death, if you do it too soon. Long-term survival with liver transplantation is amazing these days. You look at this child who was one of the children transplanted at Children's Hospital Los Angeles in 1998. Here is a surgeon, Dr. Ginnick, who did it with the medical director at that time, Dr. Danny Thomas. This is the same child now, a young lady in 2016, again with the same surgeon and a physician standing there with a new child who just had a liver transplant and now together. So are we done with? Is this cured? These are our current medical and surgical directors, Dr. Carter and Dr. Etesami. The question is transplant the only thing we can offer these children? This is a very nice cartoon from Professor Ott in Belgium, one of his older papers from 1998, where a child is receiving a piece of a liver from an adult. So the question today, though, in 2024, is whether there is a transplant not being the correct choice. Can we start to think about a different way to deal with this disease? And that's where the future directions come in. For me, a disease is when you take a medicine, when there's not a normal functioning issue. And for transplant, when even if you have a functioning graft, you have to take medicines every day to suppress your immune system. So for me, if you're taking a medicine, that means that there's something wrong inside the body. You have exchanged biliary atresia, where you would have been unfortunately, a child with biliary atresia whose Kasai is not working, or they did not get a Kasai, or before the days of Kasai, all children with biliary atresia would pass away under 2 years of age. So this was a unmanageable problem and transplantation, we are now exchanging it to a problem which can be managed, which is what I see is the definition is that, yes, we have to take a pill, we have to have interventions when there are complications, but at least it is a manageable problem. So we're exchanging a problem with a dead end with a problem that we can manage. Ideal outcomes have been defined by international groups for liver transplant in children. Dr. Vicky Ng led this from the Studies of Pediatric Liver Transplant Research Group. And what they said, and I'll go down to the basics here, is that you have all of these positive things where they have not had retransplantation, no chronic rejection, liver tests are normal, and so on and so forth. That is only present in 30% of children who have had a liver transplant and are out for 10 years. So it is not the majority of children who have ideal outcomes. Therefore, again, I restate, it's a manageable problem that we are having to deal with, which is called liver transplant. Behind the curtain, of course, there's many other injuries happening to kidneys and diabetes with these drugs that we have to give to suppress the immune system. But these are issues we have to deal with because otherwise it was a dead end. This is a more recent kind of comparison between Kasai procedure and the length of native survival versus outcomes of liver transplantation. Came out in 2021. The Kasai group, 154 patients versus no Kasai group was compared with 43 patients. And again, there is this comparison which is made but I think it boils down to the individual patient. And as Ms. Farah Douglas said at the very beginning, these discussions should be done with your individual provider at that time. So to round out the future, very briefly, I will mention there are multiple trials going on for biliary atresia with different medications. I will not talk about those medications today. We are also understanding that there may be hints of certain types of biliary atresia that are driven by susceptibility genes, not causality genes, but susceptibility genes. One of them has been highlighted as PKD1L1 or polycystic kidney disease 1-like-1 gene. And these variations have been picked up in children with biliary atresia splenic malformation syndrome, where they have polysplenia and situs inversus. They were doing rapid whole genome sequencing. A lot of states across the country, a lot of institutions across the country, as soon as a child is born, they're thinking about just rapidly sequencing their whole genome. They call them Project Baby Bear, Baby Deer, and so forth in different parts of this country. And maybe those things will help us in the future to pick up on these gene sequences. Miss Ashley Upton is a radiology technician down at Texas Children's in collaboration with Professor Sunny Harpavat, who I mentioned early on with his seminal paper back in 2011 in pediatrics. Their most recent contribution to the literature they presented a couple of weeks ago at the American Association for Study of Liver Disease meeting about a ultrasound technique to find the bile duct itself. In a child without biliary atresia, they are showcasing under number 3, and thank you for them to them for sharing these slides with me to share with you. You can see the duct here at the hilum of the liver. Versus when you have biliary atresia, you do not see that duct at the hilum. They are talking about this as a potential quick way to jump start the process of diagnosing biliary atresia, getting to the intraoperative cholangiogram more quickly. From their pilot study, again, this is not published yet, but this was just presented in abstract form at the meeting 2 weeks ago. They were able to see a sensitivity of 100% and a specificity of 94, 95%. So really strong pilot data to be proven, of course, in subsequent multi-center studies before we can use it. So to summarize, Kasai for short, since the 1950s and when Professor Moria Kasai developed this procedure, continues to be the palliative procedure of choice. We need to identify these patients early so that we can give the best possible outcomes from the surgery, the palliative surgery, the Kasai surgery. So screening, identifying direct bilirubin, stool cards, very important. Transplantation, when children fail Kasai or when they fail Kasai over time, definitely going to be cared for at a transplant center so that they can be evaluated in time, and living donor options, if needed, need to be discussed. So following these children closely, even after a successful Kasai, is important. And then future therapies. Of course, there are medication therapies. Again, I didn't talk too much about them today. Diagnosing, screening, all of these things are coming in the future. So please stay tuned. And I will stop here. Thank you so much for your attention.
Thank you, Dr. Kohli. That was wonderful, wonderful presentation. Personally, I learned a lot. Biliary atresia is a disease that I see a lot among our patients. So thank you for all that information. We are going to now move to the second part of our presentation today, webinar today, which is a roundtable. In this roundtable, our doctors will talk among themselves. They will answer the questions I have received, but also they will talk about their own experiences of working with liver patients, especially biliary atresia patients. It is my pleasure to introduce Dr. Kambiz Etesami. Dr. Etesami is Director, Abdominal Transplantation, Children's Hospital, Los Angeles, Assistant Professor of Surgery, Transplant, and HPB Surgery, Keck Hospital of USC. Dr. Etesami received his medical degree from the State University of New York, Downstate Medical Center, College of Medicine. He specializes in adult and pediatric liver, bowel, kidney, and pancreas transplantation. He additionally performs HPB surgery, which relates to liver, pancreas, and biliary system, incorporating both traditional and minimally invasive techniques for the variety of benign and malignant conditions. His medical interests include the expansion of organ availability and transplantation with a focus on living donation and maximizing utilization of extended criteria organs and management of advanced hepatobiliary and pancreatic neoplasia. He is an active member of the American Society of Transplant Surgeons. He is an associate fellow with the American College of Surgeons. Dr. Etesami is a member of the Liver Health Foundation's Medical Advisory Council. Dr. Etesami, welcome to the Biliary Atresia webinar. Thank you for your participation and time tonight.
Thank you so much. Thank you.
Thank you, Doctor. I am pleased to introduce Dr. Jaslyn Singh. Dr. Singh is the Assistant Professor of Medicine at the University of California, Los Angeles. She graduated from Washington University in St. Louis, after which she dedicated 1 year to City Year, which is an AmeriCorps program focused on tutoring and mentoring high school students in the schools with low graduation rates. She graduated from the Ohio State University College of Medicine and completed her internal medicine residency at gastroenterology fellowship at Loyola University Medical Center. She finished her training in transplant hepatology at University of Southern California, USC. Dr. Singh has been involved in clinical research in alcohol-related liver disease and hepatocellular carcinoma. She treats a spectrum of liver disease and cares for patients after liver transplantation. She is board certified in internal medicine and gastroenterology. She is a member of the Liver Health Foundation's Medical Advisory Council. Welcome, Dr. Singh. Thank you for your support.
Thank you for inviting me, Farah.
Thank you. Over the past few days, I've received questions and comments from the audience, as well as those who couldn't be with us. I have submitted the question to our presenters. We're going to review them tonight, those who have not been answered through the presentation that Dr. Coley just presented. To start the roundtable, I would like to read a comment that one of our liver patients has sent it. I think this case may be one of the rare cases. Devon says, I'm a liver transplant patient and had biliary atresia. I was fortunate to get a transplant at 8 months old. I also have sickle cell. I had a kidney transplant in 2023. On October 29, 24, I turned 21 years old. I'm going to college and I'm planning to study engineering. So, Dr. Coley, is this receiving liver transplant as a sickle cell patient and then needing a kidney transplant a rare situation, or does this happen often?
No, first of all, congratulations to him for his engineering studies and best wishes for future for his health and for his career. Unfortunately, this is a very rare combination, at least. If you look at the numbers for biliary atresia, we're talking about anywhere from 1 in 8,000, 7,000 live births to 15,000, 20,000 live births, depending on the ethnicity and geography that we are looking at the epidemiology for. On top of that, layering sickle cell disease, that is even a combination of 2 different rare disorders. So I unfortunately think this individual has had a deck of cards dealt with him that is not the best, but he has made an amazing lemonade out of his lemons, and he is now studying to help other people. So I again congratulate him, but it is a very rare situation. I'd love to hear what Dr. Etesami or Dr. Singh have to say.
No, I concur. I think it's very unusual to have both conditions, and thankfully, kidney involvement did not occur at the same time as he needed the original transplant, because at that young age, doing a combined liver and kidney transplant is very, very morbid and difficult, but it's unusual.
I will
Dr.
also
Singh?
just add that I think that's, quite rare, and also even more amazing that despite having sickle cell, that, he's done so well and is studying now. So that's amazing for him.
Dr. Kohli, in your speech, you talked about the time, kind of like a time limit for when Kasai is really effective. So, for example, Devin got his at 8 months old. So that was outside the time we were talking about. Is there like every infant has that limitation? If the doctor doesn't recognize that the child has biliary atresia, that child is really in risk for his or her future well-being.
Farah, I think just want to correct. I think he probably had a liver transplant at 8 months of age,
That's
which,
true.
yeah, the Kasai procedure is time sensitive. As I mentioned, time is bile in a funny way, if I wanted to say it, or some way to remember it, because bile flow over days and weeks is slowing down as the scarring of the bile ducts, the fibrosis of the liver tissue and bile ducts and gallbladder is happening and is progressing every day. Actually, there was a study done by one of our surgeons, Lorraine Kelly Kwan. She used a database from the Southern California Consortium and was able to showcase that for every day you delay the Kasai procedure, there is a 2% decrease in chances that there will be a successful Kasai. And that may be a small study, but the point is not the percentages are not important, but the concept is important. This is a progressive disease, and the sooner we can identify less than 60 days, typically the outcomes are better for Kasai. As we get further and further away from 60 days, beyond 90 days, there is very little chance of success. And most pediatric surgeons will not even attempt a Kasai after 120 days. So I think this here is where I talk about a pediatric liver disease emergency, in that the response has to be in days, not over months.
Mm-hmm. Dr. Etasami?
No, and I would just echo that another key component is to have a pediatrics team, especially maybe on the surgical side, because that understands that Kasai, for the most part, for most children, statistically, whether it's over the short or the long term, is really a palliative surgery. And so if you have a child with advanced disease at the onset, that the Kasai is not done, that maybe the diagnosis is made, that we identified that the child does have biliary atresia, and a liver biopsy is also taken to confirm the extent of liver disease, but that the Kasai operation itself is terminated in favor of just getting that patient evaluated and listed for a liver transplant, because doing the Kasai on a child with advanced liver disease really is not helping them. It's just belaboring the transplant and making that definitive surgery much more difficult to do.
Mm-hmm. Dr. Singh, you talked about that you have seen adults that had had BA, and then you've seen them after liver transplant. Would you like to share some of your experiences with working with those patients?
Yes, I think the majority of the patients that I see are those who underwent liver transplant successfully and are transitioned from the pediatric team to the adult team. And I think they sort of have their own types of challenges, in terms of transitioning and living essentially lifelong with a chronic medical condition that can be quite detrimental. And so I think we really respect our pediatric colleagues and getting, you know, a good sign out and transition, and knowing that these patients often require, you know, special care, you know, especially having lived for so long with a liver transplant, you know, dealing with things like chronic rejection is something that we also commonly see. And so, you know, fortunately, it's the timely identification, diagnosis, and intervention in the pediatric setting that allows me to be able to see them in the adult setting. So.
Thank you. Dr. Coley, how do you monitor? I know, for example, you have a patient that we both know, and now she is a teenager, and she had Kasai when she was newborn. How do you monitor? What's the process of monitoring? I know she visits you often. How do you monitor a child that had Kasai and lives with her native liver right now? She's very active, she's very athletic, she's healthy, she looks great. How do you monitor their health?
No, for sure. I mean, it's a collaboration between the parents, the primary care provider, if it's a pediatrician or family practitioner, and ourselves as liver specialists. Once you have a successful Kasai, we want to monitor your growth. We want to monitor your liver function. We are able to do ultrasounds to look at how the liver is doing, how the spleen is doing. These days, we have special ultrasound-based technologies in the clinic. We call them point-of-care ultrasound, such as VCTE, which is basically looking at the stiffness of the liver. We can monitor that once a year. So there are definitely things that together with the family that is monitoring for signs, subtle signs of changes in terms of growth with the pediatrician. All three of us together are going to help this child get to be the best they can be.
Do all BA patients eventually need transplant at some point in their life?
Probably Dr. Singh sees some patients on the other side of the spectrum. Um, uh, if you remember the curves graphs that I showed you, there is a pretty steep drop off as we go further away from the Kasai surgery. Dogma, historically, we've been taught a third, a third, a third, meaning a third of the children will have unsuccessful Kasai. Total number of Kasais. A third will get into young childhood, and a third will get into young adulthood without need for a liver transplant. However, there's anecdotes that I have heard, and maybe Dr. Singh or Dr. Ethesami, who deals with adult patients as well, can share their oldest anecdote of individuals who have had a successful Kasai and are still living without their livers being changed.
I definitely don't see this commonly, but I unfortunately have one patient who I have to see quite often. So, you know, she did have a Kasai. She's actually currently listed for transplant with us. You know, she's had significant portal hypertension, but I think in Mr. Presentation, Dr. Coley, I'm sure you discussed too that, you know, she's had recurrent bacterial cholangitis, and it becomes very difficult because of the surgery. There really is no intervention that can be done. And so she, you know, is repeatedly admitted for having, you know, bacteria in the blood, infections requiring hospital admission. And so thankfully, we've been able to get her a higher score on the liver transplant list, and she's still awaiting. But, you know, other challenges that come in that population are, you know, the desire to conceive, you know, counseling patients on that. Unfortunately, having the pressure on the liver, portal hypertension can, you know, complicate, you know, especially something like pregnancy. So I think, you know, from what I've seen, I think it's very difficult when they have not yet had a liver transplant.
Okay,
Yeah,
Ethesami?
and sure. Yeah, I'll just echo the same thing. It's there is publications and reports and case series of very long-standing successful Kasais, but in general, there's, like Dr. Coley said, a steep fall off from that curve. And it actually, those patients, it's a double-edged sword. On the one hand, you are starting your transplant journey later on, and so the effects of things like immunosuppression, the viability of that liver over the long run start at a later date. But by the time those now young adults or adults come to transplant, they're often sicker because now they're suffering from prolonged portal hypertension and its manifestations. And when you do a liver transplant on a young adult who's had a Kasai, that surgery is generally a much more morbid operation because the risks for things like blood loss and visceral iatrogenic or inadvertent damage is higher in general. So, those patients have been living with an unhealthy but sort of viable liver for a long time that's been resistant to good blood flow, so they develop chronic manifestations of end-stage liver disease. Again, I think the key point is to identify patients that are not Kasai candidates to begin with, that they need to just undergo a liver transplant, or to identify those who have failed their Kasai again as early as possible and try and get them transplanted sooner than later.
Mm-hmm. We have a patient with us. Aaron, could you tell us how old you were when you had your Kasai stopped working and you had to have transplant?
Yeah,
go
sure.
ahead.
Hi, everybody. Aaron Jackson. I received my transplant at I received my transplant at UCLA. I was 36 years of age when I received my first transplant, and my second transplant was 37, about 5 weeks later, when I received the liver and kidney transplant. However, I didn't feel the effects of liver damage until I was about 33-ish, is when I started to like slow onset of liver failure. 33, 34.
Is this unusual, doctors, for somebody to feel the effect of liver failure that late in life?
I congratulate you on your successful transplants, Mr. Jackson, and I agree, Farah, that this is, as you've seen the data that I presented, Mr. Jackson is one of the lucky ones.
Yes, and he had shared with us before, and it's going to be on our website, his story that how difficult when it happened, when liver started deteriorating, how difficult it was on him, and how he had a lot of different issues. But he's lucky; he's all together. He's doing great. So that brings a question up: is I don't know if maybe I missed it. Is BA a genetic condition?
Biliary atresia, as far as we know, is not a genetic condition in the sense that there is one gene that you have a mutation and you end up with the disease. There are some genetic susceptibility genes, ciliopathy genes specifically, that are now being discovered, trying to be better understood, but they're not causality genes. The bottom line is we do not understand what triggers this response of the bile ducts to get scarred down in a young infant. There are hypotheses, long-standing ones have been about a viral infection, intrauterine or delivery, triggering that response from the immune system. There have been studies to intervene with that immune response with either steroids around the Kasai procedure, plus minus intravenous immunoglobulin. But unfortunately, those studies have not given definitive answers. So for now, we are still in the mode of understanding this disease, within which there are some genes, such as the one I mentioned, the PKD1L1 gene, that have come up as signals, but not as causative signals, just as susceptibility signals. And that too, that gene came up in a small subset of biliary atresia patients known as syndromic biliary atresia, or BASM, biliary atresia syndromic malformation. So was a splenic malformation syndrome. So to short answer, we don't know. long answer, we're working on it.
Yes. Anything else, Dr. Singh or Dr. Epesami, you want to add to this answer? No?
I defer to Dr. Coley.
Yeah. So another question, and again, I'm not sure if you mentioned that or not, Dr. Coley, is can you explain the difference between isolated biliary atresia and biliary atresia with birth defects?
Yeah, I briefly mentioned it. That's what I was alluding to, the BASM scenario, where you have not just a stricturing fibrosis, progressive cholangiopathy of the bile ducts, which is the defining element of biliary atresia, but also other congenital malformations alongside, one of which is where you have the liver and sometimes the other abdominal organs flipped, what we call situs inversus. We also see sometimes the spleen, which is typically on the left side and is a whole organ, having small grape-like branches instead of a whole organ. So we call that splenules or small spleens, almost like a bunch of grapes. So these malformations are put together under an umbrella called biliary atresia splenic malformation syndrome. But that is a small subset of already the rare diagnosis of biliary atresia.
And anything else, Dr. Etasami or Dr. Singh?
No, I mean, I think Dr. Coley's answer
Yes.
was more than enough.
So Aaron was telling us, and Aaron, you can say that quickly, we are running out of time, that when you were growing up, you had a large stomach. Am I correct, Aaron?
Yeah, I grew up with an enlarged spleen. I had my Kasai procedure at 3 months at Children's Hospital of LA. And then after that, I saw Dr. McDermott at UCLA. But yeah, I had a enlarged spleen my pretty much my entire youth, my whole life.
Right. And Mr. Jackson, did you mention also that you have sickle cell?
No.
No.
That
Oh,
was
sorry.
another patient. Yeah.
So then probably your large spleen was because of the liver itself starting to scar down, what we call typically as portal hypertension. The blood from the spleen is going back to the heart, it has to go through the liver. So if the liver is shrinking down because of disease and getting scarred, there's going to be back pressure on the spleen, and the flow of blood from the spleen to the liver and going to the heart gets kind of a higher and higher pressure. So we call it elevated or portal hypertension. And that's what pushes the spleen to become larger from that back pressure. So that's probably why you had a large spleen. It's one of the signs of chronic liver disease, which Dr. Etasavi and Dr. Singh are unfortunately very familiar with.
Dr. Singh, you want to add something to what we heard?
Yeah, just similar to what Dr. Coley was saying, in the adult population, I think that's something really for us to look out for after the Kasai procedure, or those the patients that have portal hypertension that may suffer consequences from that.
Dr. Etasami?
Same thing. Yeah, it's just it's the blood has more resistance. There's back pressure. The spleen normally is a largeable, sizable reservoir for blood and blood products, so it kind of expands because of that pressure. And especially in young adults, older children, you have to worry about if they participate, say, in any contact sports, and there's trauma, the spleen can bleed excessively because of that.
Yeah, and I believe, Aaron, you heard that as you were growing up, right? No contact sports.
Yeah, I heard that quite a bit. I really wanted to play football, but that was out of the question. They allowed me to play baseball, but I had to wear like this, it looked like a rabbit, and it had like this plastic thing, and it covered my entire area, which was discouraging. And it took them until 6th grade when my spleen started to get slightly smaller, only because I was growing in size. that they allowed me to finally play soccer. So yeah, just basketball, baseball, and soccer. No football at all. No hard contact sports.
No wrestling either, I assume.
No wrestling either, except on the carpet with older cousins. That was about it. Who took very good care of me. But yeah, no contact sports. And I had the heart for it. I had the lion in my soul. I really wanted to do those things, but hey, it's okay.
Thank you for sharing.
Yeah.
Just one last question, and that's about diet. With Kasai, do the children have a special diet, have to avoid something? I know, for example, Molly is very careful about what she eats, and her mother is very careful about what she prepares for her.
From the diet perspective, I would stick to general healthy liver advice for anybody. We definitely want to have adequate protein in the diet. We want to avoid excessive carbohydrates, especially refined sugars. Definitely no sucrose, fructose enriched drinks. So my typical gambit is to say to the kids to make them laugh, if it's sweet and you can pour, kick it out the door. And they will snicker a little bit and remember that when they go home. So yeah, general advice, nothing out of the ordinary. Definitely they will need sometimes additional multivitamins, especially fat-soluble vitamins. And so we will supplement them as and when needed.
Dr. Etesami, anything else? No?
No, I think you just the point, you need bile to absorb fat soluble vitamins like vitamin K, for example, and when you don't have good bile excretion into the intestine, that absorption doesn't take place. So you need supplementation of that.
So no ice cream? No chocolate?
This is the season to be merry, so I think
Yes.
saying no to chocolate is very hard for
Yes.
anyone, including myself. But I think the amount of sugar that is in drinks is very, very high. So for sure, no sugary drinks. We can make exceptions for chocolates.
All right, great. I'm happy about that. Dr. Singh, anything else you would like to add?
No, I agree with everything.
Well, thank you. We are grateful for our excellent experts, and thank you, Aaron, for sharing your story and your question. Thank you. I believe this was a very informative roundtable and a great educational webinar. We hope everybody received new and important information. I want to thank especially our doctors, and I need everybody to know that our presenters are here as volunteer physicians. They care deeply about liver patients, about you. They own their own personal and family time and share their expertise with all of you in support of our efforts in helping liver patients and also raising awareness of liver disease. My personal heartfelt appreciation to our doctors for their kindness and compassion. Really appreciate what you do for us and what you are doing for liver patients. So thank you, Dr. Kohli. Your presentation was wonderful. We are grateful for your support tonight and for your many years of partnership with us. Thank you, Dr. Singh. Liver Health Foundation is grateful for your continued support. Thank you, Dr. Etesami, for accepting our invitation and participating in this webinar. You added very crucial information to the webinar. Aaron Jackson, thank you for adding your personal experience to the webinar for those who are living with Kasai procedure. Liver Health Foundation will host another educational webinar on 23rd of December from 5:30 to 6:30 p.m. It's called viral hepatitis, and we will have doctors talking about viral hepatitis. So please visit our website so you can join. We are on all social media sites and YouTube, so please visit us, leave information for us. You will see our notes about our upcoming events on our social media and other sites. So thank you, our doctors. Thank you, Aaron. Thank you for joining us this evening for this important webinar. We wish you a happy and safe holiday season. Be well, take care. Thank you, and good night.